You know the archetype of the bad kid, the student who gets into fights, destroys property, repeatedly breaks rules, and walks away without remorse. In the Diagnostic and Statistical Manual of Mental Disorders, this persistent pattern of violating the basic rights of others has a specific clinical label: conduct disorder. Society's default response to this behavior is immediate modification and punishment. We use point systems and token economies. When those fail, we escalate to suspensions, expulsions, and eventually juvenile detention facilities. But for a massive subset of these children, particularly those moving through the foster care system, these traditional behavioral interventions fail. The aggression doesn't stop. A thrown desk looks like a deliberate choice, but the clinical diagnosis of a fixed, calculated desire to break the rules often hides a different mechanism entirely. By punishing the outward behavior without understanding the biological state underneath it, we trap traumatized kids in a cycle of ineffective discipline. Developmental trauma, or complex PTSD, stems from chronic abuse, family violence, or the kind of systemic neglect seen in this historical ward. These experiences force the nervous system into a permanent state of high alert. Superficially, a traumatized child and one with conduct disorder look identical. They both yell, fight, and defy authority. However, conduct disorder aggression is proactive and goal-directed. Trauma-induced aggression is reactive. It's a preemptive strike from a brain stuck in fight or flight, constantly scanning for danger. This state is so intense that traumatized teens process visual information differently. Clinical studies show they routinely misinterpret neutral or even sad facial expressions as angry threats. When a child lashes out under those conditions, it is a survival strategy, deployed against a threat their brain believes is real. There is a second major diagnostic overlap that confuses clinicians. Children with conduct disorder often display a chilling lack of empathy or guilt after hurting someone. Traumatized children can display that same blank, unbothered stare, but for a different reason: dissociation. Faced with inescapable abuse, the brain survives by numbing the feelings of pain and hurt. Over time, this biological numbing extends outward. If you cannot feel your own pain, you cannot feel empathy for someone else's. The traumatized child appears externally identical to the callous one. Look at this archival clinical observation room. A diagnosis of conduct disorder assumes observers are watching a child with a fixed behavioral defect, but a trauma-informed lens looks at the exact same child and asks, "What happened to you?" The system sees a broken, remorseless child. In reality, it is a nervous system performing a vital biological function, surviving a hostile environment. The ultimate danger of the bad kid label is that it dictates the adult response. Assuming a child is making a choice to violate rules leads to strict punishment instead of investigation. Punishing a survival response backfires. A perceived threat causes reactive aggression. The system responds with punishment, reinforcing the belief that the world is hostile. The threat level rises and aggression worsens. Breaking this cycle means moving past behavior-first approaches, ignoring the panicked nervous system underneath. Effective intervention requires trauma-responsive care. This approach prioritizes 3 elements before addressing behavior: physical safety, predictability, and connection with a trusted adult. Establishing this baseline of safety is the only way to signal a traumatized nervous system that the threat has passed, allowing the brain to power down its fight-or-flight response. True intervention doesn't mean punishing a bad kid into submission. It means creating enough safety for a traumatized brain to stop fighting for its life.